Well, thank you everybody for joining today's webinar. We really appreciate folks taking the time. And we're pleased to have an opportunity to dig into a tale of three health systems, the mid-revenue cycle insights and road to revenue integrity with AMN Healthcare. And as many of you know, we've worked with AMN for many years with a number of solutions to address workforce issues, physician search, executive search, language services, and I can think of several recent examples where they've helped our MHA Michigan hospitals in those areas. And we even have stories to tell about how they really worked with long-term cares during the pandemic in Michigan. So really appreciate the strategic partnership with AMN. Today, we're going to dig into the revenue cycle solutions, which honestly, I didn't know as much about until we started preparing for today's session. So I'm really pleased to bring that to you today. Just a couple housekeeping items before we jump into welcoming the speakers. We are recording the session so you can share with colleagues as needed, and we'll share slides and other resources afterwards as well. But we are going to end the recording and open it up for a live Q&A at the end, just to make it more open for Q&A. So hang on the line and feel free to stick around for that at the end. And as always, feel free to drop questions in the chat and we'll address those either at the end during the live Q&A, or we'll follow up email directly with folks as needed. So with that, by way of welcome, I just want to introduce our speakers. I did include their full bios in the webinar description. We're very pleased to be joined by Christine Polian, who's the Division Vice President for Revenue Cycle Solutions at AMN Healthcare and has more than 20 years of healthcare and consulting experience. She's responsible for building service and solutions architecture for key revenue generating departments within healthcare organizations. We're also joined by Anne-Marie Gerard, who's Senior Director of Workforce and Quality at AMN Revenue Cycle Solutions, and is a fellow Michigander. She has more than 20 years of experience addressing revenue cycle issues for healthcare organizations, including time worked at Henry Ford and Beaumont, and she's an active member of AHIMA, HIMSS, and the Michigan chapter of HIMA. So again, really appreciate everybody taking the time, and I'll turn it over to Christine to kick off today's presentation.
Thank you, Rob. Rob did not mention that I am from Ohio, but I am not an Ohio State fan, so I'll put that out there. So today we are going to talk about revenue integrity today, our drivers, our challenges, and financial impact. We will talk about what works in practice, and we have 3 case studies to go over with you. We will talk about operational levers that matter, length of stay, documentation integrity, coding, and denials recovery. And then we will also talk about enablers of success, technology, artificial intelligence, and human oversight. And then we have takeaways for you. Practical strategies to improve accuracy, reduce denials, and strengthen integrity, revenue integrity. I work from home and I don't get out very much. And so I decided that because I don't get out very much, that I was going to treat myself for some coffee, and I keep it very, very simple. It's a medium dark roast. I'm in and out. And last week I had this burst of energy and decided that I was going to order something that was very complicated, half calf skim, extra hot, that sort of thing. And when I got there, because I'm there every week, I expected that it was going to be ready. And when I walked in, the barista was juggling 3 different things. It was not ready. He's spilling milk. He's fighting with his very rebellious coffee grinder and trying to stay on pace with this growing line of orders. And after what felt like an eternity, I'm thinking to myself, okay, I really should just go home and make my own coffee. And then something happened. The barista did not give up, did not wait for someone else to fix the equipment, did not shut down the line, and instead he got creative. He grabbed a straw. He used it to MacGyver the top of the grinder, and against all odds, got it working. And a minute later, I had my very complicated $7 drink in my hands, And when I took that first step, I thought to myself, this is exactly what we do with our revenue cycle clients every single day. We are working inside of complex systems that don't always behave the way that we expect. We are facing spills and delays and backlogs and bottlenecks and equipment, whether it's literal or metaphorical, that sometimes just refuse to cooperate. And yet we keep finding a way. We troubleshoot, we improvise, and we apply expertise. We build workarounds that get things moving until we can find the root cause. And we prevent the milk spills from turning into operational breakdowns. We're always looking for the cleanest and the fastest way to keep things moving, all while balancing compliance, timeliness, and sometimes revenue cycle. It's not always glamorous. It's not always the fancy drink, but it is the engine that keeps everything running. And like that stubborn coffee grinder, we are experiencing great pressure and challenges, and it's growing every single day. And we know that every executive on this webinar, we know that you feel those challenges and the impact. And the rising denials and the delayed reimbursement, they've reached unprecedented levels. Documentation gaps, they continue to erode case mix index and quality performance. And despite treating equally sick or even sicker patients post-COVID, many systems are watching their CMI steadily decline. At the same time, length of stay variability and avoidable days, many expected those would normalize after the pandemic, and they have actually increased in many cases. When we think about technology and artificial intelligence, both have become central to the conversation, and they should. We can't simply solve everything and all of our challenges with staffing and manual effort alone. Automation, it accelerates throughput and it improves accuracy, and predictive tools can flag denials and documentation risks and length of stay concerns before they materialize. However, selecting the right technology for your organization, we know that that is not simple either. And despite the hype, technology, it's not a replacement for clinical and financial judgment. The balance between digital enablement and expert oversight, it isn't optional, it is absolutely imperative. And when we think about operational complexities, we actually did something interesting, and we compared COVID era years to non-COVID era years. Something surprising emerged. Contract labor spend went down, length of stay went up, and consequently, length of stay related costs increased as well. This raises critical questions. Are staffing shortages contributing to increased length of stay? Is reduced contract labor masking specialty skill gaps? Or are financial pressures limiting staffing investments in ways that unintentionally elevate operational costs? The reality is likely all three. And one thing is certain, workflow fragmentation across clinical and financial teams is real. We see it daily. Siloed processes, limited visibility into root causes of revenue leakage, and teams that are working incredibly hard without a full view of the entire operational ecosystem. So why does this matter for C-suite? Well, it's your revenue integrity. It directly influences your margin, your quality scores, your competitive position, and your long-term sustainability. Every dollar truly matters. Every process variation, every coding miss, every preventable denial, every avoidable day, it all compounds across an enterprise. Next, Anne-Marie will talk to you about key drivers. Next slide.
Thank you. When we talk about revenue integrity, we're really talking about the foundation of financial stability in healthcare. It's not one function or one department. It's an end-to-end strategy touching clinical ops, coding, denials management, technology, and leadership alignment. So specifically, when we're thinking about care management, reducing length of stay isn't just about cost containment. It also creates net new revenue opportunities. Efficient throughput improves capacity, supports patient flow, and strengthens overall financial performance. With clinical documentation, It absolutely must reflect how sick the patient is. Accuracy is critical because it tells the full story. And when documentation is complete and specific, it directly impacts case mix index and reimbursement, ensuring the organization is appropriately compensated for the care delivered to that patient during their stay. And with coding, it's all about best practice. Best practices are key. Strong coding practices reduce errors that lead to denials and compliance risk. Consistency, accuracy, and adherence to best practices help protect revenue while maintaining regulatory integrity. So when you're thinking about your denials management program, it works best when workflow supports proactive versus reactive. Audits, root cause analysis, they all allow recovery of lost revenue, but more importantly, helps to prevent the same issues from recurring in the future. Technology is the common thread across all three drivers. Automation reduces effort. Predictive analytics help us identify risk earlier up the chain. And AI-driven tools can surface documentation gaps in real time, improving accuracy and supporting remote workflows. However, let's not forget, human oversight remains critical for nuanced clinical judgments and compliance assurance. So we're going to walk you through the AMN partnership with three very different healthcare organizations and share how we integrated the key drivers into a cohesive strategy, which resulted in improved financial performance, enhanced quality scores, and a stronger reputational standing. So now I'm going to turn it back to Christine to walk you through the first case study.
Leading off with length of stay. What would you do with $90 million? Next slide. Our first case study focuses on a large nonprofit health system in the Southeast, operating approximately 50 acute care hospitals. This organization was at an inflection point and recognized the need for meaningful innovation within its care management infrastructure. And we engaged with the senior leadership team. They were facing several critical challenges. They had significant vacancies across care management departments with a growing inability to fill those positions. They had retention issues with competing organizations attracting their care managers by offering fully remote roles. They had an upcoming Epic Go Live. They had a cohort of novice care management leaders in need of structure and guidance and support. And most concerning, a 13-month trend of worsening length of stay performance, a trajectory that just simply was not sustainable. So to better understand the root causes and quantify the problem, we conducted a detailed analysis. I was one of the architects on the engagement, and my initial role was to lead that data review. And the system's executive director of care management came to us with this charge. Help us rethink our staffing model. Help us reimagine care management and help us identify a solution that we can confidently take to senior leadership. They provided a robust data sample from one of their regions, 4 months of data across all discharges. This allowed us to conduct a comprehensive length of stay assessment and uncover operational patterns driving their performance trends. This 4-month snapshot ultimately became the turning point. It provided the evidence that we needed to make a case for innovation, and it set the stage for a completely new way of approaching care management for the system. So let's talk a little bit about that data. We had 10 facilities in that particular region. There were 3 facilities that we thought were really interesting. Their discharges over the geometric mean ranged from 40 to 48%. So 40 to 48% of all of their discharges were over the GMLOS. 7 to 12% were 2.5 times over the GMLOS. Their open full-time positions varied from 0 to 6 full-time positions, and the estimated avoidable day cost in the region for just those 4 months, $30 million. One facility in particular stood out at $10.7 million, that highest cost. It also had the highest, obviously the highest number of net days. It also had the highest number of open positions. When we looked at the total number of days over the GMLOS, it was over 37,000 for that 4-month time period. And then for fun, we thought, okay, what if they do absolutely nothing at this particular point in time? What would it be on an annualized basis in terms of cost? $90 million. The patterns indicated a relationship between staffing levels, GMLOS variance, and cost pressure. So our pitch that we took to the senior leadership, while the data definitely informed the approach, the true value of the pilot, what ultimately drove the alignment among stakeholders, not the $30 million, it was the ability to meaningfully reduce reliance on contract labor. Just as importantly, the pilot would create additional capacity for the on-site care management team, enabling them to redirect their time and their expertise towards more complex and high-need patients. To play off of the theme of seeing things differently, the solution that we came up with the pilot, I'll tell you, it was not complex like my drink. It was very simple. Our strategy was to transition to hybrid on-site and remote care management services. This enabled conducting initial evaluations remotely for discharge planning with the next calendar day, and then performing a handoff to the on-site care manager. With the initial evaluation taking approximately 30 minutes, we anticipated freeing up 2 hours a day for the on-site care managers, giving the care manager the time to focus on complex patients, attend MDRs, coordination of care, progression of care across the continuum. To drive alignment and secure buy-in across the organization, the team deployed a comprehensive communication and engagement strategy, including targeted messaging, informational flyers, sound bites, and MDRs to ensure that we had clarity and consistency for all stakeholders. We launched a formal on-site kickoff. We brought the on-site care managers together with the remote care managers so that they could establish rapport, share expectations from day one. The remote care manager was also paired with our transformational leader who worked very closely with the on-site director of care management. And this leadership structure was crucial. It ensured the quality and consistency of the initial evaluations. It provided real-time troubleshooting for operational barriers and enabled immediate remediation when issues arose. In addition, the transformational leader assumed responsibility for daily patient prioritization, removing this burden from the on-site management team and ensuring a smooth and dependable workflow throughout the pilot. From a technology standpoint, this was a pilot. So we operated in true proof of concept, requiring us to maximize existing resources rather than invest in new infrastructure. AMN supplied laptops for the remote care managers, and patient outreach was conducted using in-room hospital phones. All documentation was entered directly into the EMR to maintain integration with current workflows, and given the nature of proof of concept, no additional budget was allocated for new technology solutions, so we focused on optimizing what was already available. To maintain accountability and transparency, the organization leveraged existing Power BI dashboards to monitor performance, and we held weekly operational reviews to assess challenges, wins, analyze key metrics. Every opportunity day was tracked unit by unit, enabling us to understand trends in real time, evaluate case mix impact, monitor compliance, and ensure that initial evaluations were consistently completed within the required 24 to 48-hour timeframe in order to meet conditions of participation requirement. Let's review the outcomes of this pilot. In just 4 months, the program delivered 2,150 opportunity days saved. That represents 1.4 million in avoidable day savings, a 363% return on investment, and additionally, we observed a 20% increase in patient satisfaction, a 20% increase in on-site care management morale measured through pre- and post-pilot surveys. These results were achieved despite significant external pressures, including multiple tropical storms and the aforementioned Epic conversion, further validating the strength and the adaptability of the model. As expected in a pilot environment, we encountered several operational challenges as well. Early on, we learned that not all patient rooms were equipped with phones. That created a barrier when trying to reach the patients. We also identified initial communication gaps between the remote and on-site care managers. And so to address this, we standardized handoffs through Microsoft Teams and engaged the transformational leader to reinforce expectations. These corrective actions improved workflow consistency, increased the number of initial evaluations completed each day, and ultimately returned, as projected, 2 hours per day to on-site care managers partnered with remote staff. That was time that they were able to invest in managing higher acuity, more complex patients. Importantly, none of these outcomes would have been possible without the close collaboration between our financial teams and our clinical teams. Their shared commitment and alignment and ongoing partnership were absolutely essential to ensuring the success of this pilot. We replicated the pilot at another flagship facility in their central region. Between the two, we saved a total of $3.1 million in net savings. The savings and the net new revenue gained from opening the beds enabled the pilot to turn to practice in day-to-day workflow and implement a new technology to support a broader remote mission. Next, we'll talk about when quality and revenue collide. Next slide. We believe that if you focus on quality, the money will flow. Our second case study follows quality and revenue with a new clinical documentation program. This program began in response to a significant quality concerns. Another care management leader facing persistently low performance engaged us and connected our team with their vice president of quality. The organization, operating 2 campuses in the Southeast, had no formal clinical documentation integrity program, and core quality metrics reflected this gap. Readmissions in the 18th percentile, mortality rates in the 32nd percentile, and a case mix index below the 25th percentile compared to peer facilities. From a financial and operational standpoint, the challenges were equally substantial. To secure project approval, we needed to demonstrate meaningful revenue. You've all heard this before. No money, no mission. We conducted a DRG variance analysis and we identified $9.2 million in likely unbilled revenue, $7.2 million in avoidable day costs, and a compounding problem of long lengths of stay combined with low CMI. Additional findings raised further concern. For a trauma facility, we found no trauma activation fees and minimal utilization of SDOH codes, resulting in additional revenue loss. Our solution required building both a structural foundation and operational framework from the ground up. We developed a full program architecture, including policies, procedures, governance structures, job descriptions, and end-to-end workflow. And we worked very closely with key stakeholders to socialize the program, secure buy-in, and educate physicians, and also support the hiring process. Because the new team consisted of RNs and they had absolutely no prior CDI experience, we implemented our proprietary training model, which included an academy and then also a structured immersion and oversight phase. This enabled rapid skill development and consistent review quality. So let's talk about technology. Well, given that this was a startup, investing $500,000 in CDI technology, that just wasn't feasible. However, relying on sticky notes and spreadsheets, that was equally unacceptable. So we pulled out our straws. We built a robust technology-enabled workflow using Microsoft Lists. It was our operational backbone. The team documented all reviews, queries, follow-ups, DRG shifts directly into lists. It also prioritized for us. It updated in real time. We also created all of our reporting and designed it to integrate into Power BI so that we had dashboards that pulled the data from list, and we had scheduled intervals so that we could support our weekly, monthly, quarterly reporting. We knew that there was revenue that was sitting on the table, so to avoid leaving it there during the infrastructure, we deployed an experienced clinical documentation improvement specialist as boots on the ground. And this individual performed concurrent reviews, also educated the providers, and created an immediate revenue lift, enabling our senior consultant to stay focused on developing the new team. Let's talk about these results. Over the 7-month engagement, the program delivered measurable improvements in both financial and clinical performance. But first, I want to talk about what happened in the first quarter. With 2 newly trained CDI RNs, they were able to capture a net impact of $452,000 with a 15% improvement in CMI. Sepsis and encephalopathy were 2 of the main drivers, and if we tie that back to the DRG analysis pre-implementation, it wasn't a surprise to us at all. In project total, $1.53 million in net revenue generated, 17.5% increase in case mix index, a 22% improvement in mortality rates, and 72% improvement in readmission rates over time. These results validated a focused investment in quality not only improves patient outcomes, but also drives substantial operational and financial gains across the organization. It again would not have been possible without the clinical and financial teams working in concert to achieve a common goal. We had an incredibly engaged group with the CMO, the CFO, the VP of quality. They were just a tremendous group to work with. Present day, we are back helping the team expand and evaluate CDI technology, thanks to the ROI that was achieved. Up next, Anne-Marie will dive into a case study number 3, focused on performance and partnership.
Okay, so we're going to take a close look at how a large multi-state for-profit health system achieved coding excellence through a comprehensive revenue integrity approach. The organization in this case study is one of the largest health systems in the country, operating in nearly 70 hospitals across 17 states, more than 10,000 beds, and over 360,000 annual discharges. The case study is a result of an AMN team member's long-standing relationship with the business owner, grounded in open communication, reliable execution, and a high degree of trust. And through this partnership, AMN has been able to deliver in-depth services with measurable and high-impact results. So as you can imagine, revenue cycle operations at this scale is extremely complex. And the complexity increased as the system expanded through multiple mergers and acquisitions. And they acquired new hospitals, outpatient facilities, large physician network groups. And each acquisition brought the pressure to scale quickly while balancing revenue integrity and cash flow. So as we jump into the challenges, you'll get a glimpse of the pain points and how they became the catalyst for a strategic, integrated HIM and revenue integrity partnership. So let's talk workforce. With mergers and acquisitions, they created large staffing gaps and turnover was persistent. Capacity planning was a nightmare. Acute care and pro-fee coding positions were chronically understaffed. And the large array of coding specialty roles were extremely hard to fill. Technology challenges were immense with this health system. Multiple EMRs, numerous legacy archive systems, and high-risk technological failures. For one, the system endured an unexpected EMR outage, which forced multiple hospitals to switch over to downtime procedure. And this includes paper charting, which creates a very large facility coding backlog. Secondly, there was a technology platform which experienced performance issues, which led to a growing coding backlog in the outpatient space. So think of ED records, outpatient, professional fee, all the service lines. So as a result, the organization faced rising payer denials, slowing down reimbursement, and creating large cash flow challenges. So what did we do? Well, while the overall scope of the solution was intentionally broad, the true differentiator was the depth, the scale, and the quality of the talent that was deployed. This included a strong emphasis on DRG integrity, a solid performance management model, and a proven track record with delivering high-impact solutions. This enabled us to scope and scale in a meaningful and sustainable way across the organization. AMN deployed over 25 experienced acute care coders, and this managed approach ensured consistent coding quality, production management, operational reliability, and alignment with regulatory and compliance standards. From July 2024 through July 2025 specifically, the outcomes demonstrated both quantitative and qualitative financial and operational impacts. Improved coding accuracy and the implementation of a solid denial appeal recovery program resulted in a net revenue gain of $17.5 million, and of this, $4.93 million in additional reimbursement directly related to enhanced coding quality, with our coders scoring a collective 97.3%. The organization saw a substantial reduction in the backlog of denials, recovering $12.6 million in previously denied claims. Appeals performance remained strong, with an appeal success rate ranging between 80 and 85%, reflecting effective clinical and coding alignment, as well as strong documentation integrity practices. A direct result of implementing coding best practices improved timeliness of reimbursement, and the organization achieved $230 million in timely inpatient payments. The results illustrate how a scalable, high-quality coding workforce, supported by proven expertise, can drive measurable financial performance, operational efficiency, and sustainable revenue integrity across the enterprise. So now let's talk about what happens when technology doesn't perform the way that we expect it to. So the major EMR outage referred to a little bit earlier, not only did this downtime create a coding backlog, but the organization flipped to downtime procedure, which includes paper charting. Paper charting means documents need to be scanned, and the risk of long-term backlog is high, and it would have escalated into serious operational and financial risks. So to address the challenges directly, the health system called on AMN, being their long-term trusted partner, and we provided creative solutions which were comprehensive, offering multi-layered support. And this included all coding services as well as chart deficiency analysis, denial management, and clinical documentation integrity. With our long-standing partnership, it didn't take long to quickly assemble a team of experienced HIM analysts, and the mission, review the paper charting and process more than 30,000 records generated during the outage by reviewing the clinical documentation, flagging documentation deficiencies that are required for a complete and legal medical record, ultimately preserving revenue and warding off compliance risk. This rapid response team became the backbone of the recovery effort by preventing data loss, keeping the workflow moving and protecting revenue while IT worked to resolve the system failure. It was old school HIM, humans stepping in where technology could not. The system leaders were impressed at how quickly the team was assembled, the delivery model, the overall impact, and they brought the team back for additional data entry work once the outage was resolved. But balancing innovation with the understanding that people, coders, analysts, clinicians remain a vital part of every resilient system. The health system had to also implement an outpatient and professional fee coding technology solution, and it was designed to streamline workflow and improve efficiency. But shortly after they implemented, the system went down, and the outage immediately created a significant coding backlog in the outpatient space. And that backlog quickly translated into strain financially, putting greater pressure on an already stretched team. So AMN jumped in to stabilize operations. And the team of coders cleared more than 25,000 records, The rapid response served as a critical safety net while the organization worked to address the underlying technical issues. So you can see both scenarios are excellent examples of why human-in-the-loop solutions remain essential. As more advanced technology pushes us all to be faster, increase accuracy, and gain additional workflow efficiencies, there's always going to be moments when technology falters. And when it does, skilled human expertise becomes that bridge that keeps operations moving, protects financial performance, and ensures compliance. Additionally, AMN successfully piloted an innovative, scalable coding float pool that enabled 24/7 on-off staffing flexibility to align resources with fluctuating volumes and staffing needs. This model proved effective during high-impact events, including that EMR outage, and the coding float pool continues to operate successfully today and is positioned for broader enterprise-wide expansion. Next slide, please, Robert. So let's connect the three health systems. They all faced a pivotal choice and embraced the measurable value of taking decisive action. Across the multiple health systems that we talked about today, patterns emerged, and all three achieved meaningful, sustainable improvement. Each one began with strategic focus. They didn't try to fix everything. They targeted the highest impact breakpoint, identified operational friction, documentation gaps, process variations, all eroding financial performance. And they prioritize clinical documentation quality overall, always keeping an eye on return on investment. But strategy isn't enough. They aligned clinical, operational, and financial leadership, not in silos, but in a coordinated partnership. They applied operational discipline, standardized workflows, and used best practices. They invested in specialized clinical expertise and revenue cycle depth, recognizing that complex work requires skilled oversight. And accountability became a defining characteristic. All three organizations built clear ownership around length of stay performance, documentation, coding, and denials management. Team members knew their goals. They understood their metrics and they acted on their data. They understood that digital tools offer visibility, prioritization, and workflow efficiency, but clinical and financial judgment must stay human-led to protect quality. With the right oversight, technology became an accelerator and not a substitute. The organizations all reduced revenue leakage, improved length of stay variability, strengthened reimbursement accuracy, and captured new revenue. Most importantly, each and every initiative delivered a rapid return on investment, followed by long-term stability. In short, doing nothing came with a cost for the three health systems, but doing something with focus, alignment, discipline, expertise, and smart technology produced enduring transformation. Now I'm going to turn it back to Christine for the key takeaways.
So in practical terms, here's what you can do if you have not already done so. Name a unified executive sponsor team. Bring together your senior leaders from clinical, operations, and finance to jointly own an agenda rather than working in isolated tracks. And I would say also bring in staff. I think that it's important that you have the understanding of what's actually going on at the staff level as well. 2, select 1 to 5 high impact breakpoints to fix first. You don't have to boil the ocean, as they say, or eat the elephant whole. Focus on what's causing the greatest revenue leakage or operational friction. Is that documentation quality? Is it throughput? Is it length of stay? Is it denials management? I mean, you have a lot to pick from. Mandate standardized workflow and governance, require enterprise-wide operational discipline. So clear, consistent, transparent accountability. Invest in specialized expertise if you can, so that you can strengthen clinical documentation, care management, and your revenue cycle teams. Use technology intentionally with the human in the loop. And track and protect your ROI rigorously. set measurable goals, and monitor them on the regular. This now concludes the session. We're going to open it up for questions specific to the case studies or any concerns that you are facing with your mid-revenue cycle.
Well, thank you, Christine and Anne Marie. And I did just pop up the case studies with the QR codes that folks can scan and download if you're interested. We'll also have those to share afterwards. So thank you, everybody, for joining. And